visiting guest speakers, Scott MacDonald and Samir Sheth. The focus of today's presentation is on narcotic abuse and opioid overprescribing. Those who've been paying attention to this, American College of Surgeons recently recognized and acknowledged that this is a huge problem that surgeons have a part of contributing to. The Annals of Surgery dedicated the last issue in its entirety to the narcotic abuse and opioid overdose episodes, and had a significant number of articles on it. And I think just this week, one of the largest prescribing mail order pharmacies, which one is it? Was it Scripps? One of them has just said that they would limit the number of narcotics that they're prescribing per prescription, regardless of how many you write as a physician, based on diseases. So awareness, and then of course Dr. Farmer mentioned last week the issue of finding signed prescription pads laying in the wards in deaths is a violation of federal laws as well, and recently had an expose in that here at UC Davis. So the whole combination of how we manage narcotics in our patients is the focus of at least today's discussion. I'm sure we'll carry it on in the future. So gentlemen, thank you for joining us very much. Samir, you're going to begin?
Yes, I am. Thank you.
From the anesthesia and pain service, so welcome, sir. And pain service, so welcome, sir. And thank you.
Thank you. Can everyone hear me okay? I'd like to thank Dr. Jerkovich and Dr. Farmer for inviting us today, and we're really excited to speak about this topic. So can everyone hear me, just to make sure? Okay, good. So perioperative opioid therapy management. So our disclosures, we have no relevant disclosures, no off-label. So objectives, what are we going to be talking about today? Opioids in surgery, why is it important? Why should you care? Dr. Jerkovich already talked about a little bit about that, but I'll try and go a little bit more into detail about that. The issues with opioids, the benefits and the risks, and then the current state of the opioid crisis, kind of the implications of opioid prescribing or over-prescribing of opioids, and then our institutional efforts. I'll have Dr. MacDonald talk about that, and potentially future directions as well, and opportunities. So why should you care? I started looking at the journals that you guys would be reading, the American College of Surgeons, and I found a lot on opioids. So this is obviously very interesting to you guys, of interest to you guys. So I look at my pain medicine journals, and obviously I'm going to see a lot of hits, but I was surprised to see 375 just from a quick opioid search. And this was just recently. So it is something that's obviously of interest, and I think there's many reasons why. So when we look at pain and after surgery, what's amazing is despite all these things that we have tried to implement with regards to anesthesiologists, including myself, trying to try these different techniques, nerve blocks, ketamine, whatever you want, pains really remain the same after surgery. So after 20 years, studies have shown that it's really not that much different. So obviously we still need to look at this problem, figure out what we can do, all of us, not just surgeons, not just anesthesiologists. It goes from primary care, psychologists, everyone. We all need to look at this problem and delve a little bit deeper into it. So why should surgeons worry about the opioid epidemic? Understand that 40% of outpatient opioid prescriptions are written by surgeons. 49% are written by people like me, but 40% of outpatient opioid prescriptions are written by surgeons. 5% of the general population uses opioids, but those going to see a surgeon are likely going to use opioids a little bit more. They're at a higher rate. 20% of patients take opioids preoperatively. So before coming to you, they might already be on opioids. What's interesting is that even after surgery, about 3 to 10% of opioid-naive patients who underwent surgery are still on opioids, on chronic opioid therapy. So this is a big problem. There's a lot of reasons for that, but just this is absolute data, absolute numbers. And what's really more fascinating is that in one study, about 72% of opioids go unused. And that's just one. So it's anywhere from 70 to 80%, depending on what you read, go unused. And then what's really interesting is we don't know how to dispose of them. Or we're not educating people on how to dispose of opioids properly. So a couple of studies to kind of drive home that point. So there's this wide variation in excessive dosage of opioid prescriptions. This was after common general surgical procedures. This was by Dr. Hill and Barth. I believe they're at Dartmouth, if I'm not mistaken. But if you look here, if you look at some of the numbers, if I can get this. So if you look at they looked at partial mastectomy. Again, partial mastectomy with sentinel node biopsy, laparoscopic cholecystectomy, inguinal hernia repair and then open inguinal hernia repair. Looked at all cases, so about 127 cases. But basically, I just want you to pay attention again to this number of 2,500 unused opioids. 71% of after just common surgeries. This is an institutional effort to look at their opioid prescribing. So again, it just drives home that point that these are the common cases that I think we all see, and about 71% of those opioids go unused. This is, why are there so many unused opioids out there? Why does that happen? I think there's a lot of different reasons. Again, I think a lot of what we're seeing today with the opioid epidemic is good intentions, to be honest. There's very few people out there, and there are people out there like this, but there are very few people out there that are intentionally prescribing to people that are known addicts or trying to make money or purposefully diverting. There's very few people like that. But why for those that when we're prescribing, why do surgeons prescribe an excess amount of opioids? Part of it is the distance and inconvenience for patients, right? So you do a surgery and you send them home. You don't want them to be uncomfortable. And on top of that, you don't want them to have to drive back. In certain centers that I looked at, some of the research is coming from, a lot of the patients are coming from, or the hospitals are in rural centers where the patients are coming from 2, 3, 4 hours away. So it's very inconvenient for patients if they have continued pain to come back for another opioid prescription. So that's something to think about when we're prescribing. So this is why it's really important and critical that e-prescribing be implemented, or if we can now we're starting to do that in California, so to e-prescribe would really help a lot of this. So you don't have to get a written script. You don't need a triplicate form for getting a prescription refill for some of these medications. So this may allow us to write less medications up front, and then if we need a refill, we can do a refill. Obviously, there's this legitimate concern for pain. So that's one of the reasons why we might write a little bit more after surgery. Patient satisfaction. So one of the things that have come out is that on these postoperative the patient satisfaction surveys, pain management was on there. Were you satisfied with your pain? I think there's a push to remove that from patient satisfaction surveys. But really, it's an assumption because recent studies in JAMA suggest that postoperative opioid prescribing is really not associated with those patient satisfaction scores. So also just to keep in mind, but there is that assumption that patient satisfaction, if I don't get enough opioids, if I'm a patient, I don't get enough opioids, if I'm in pain, I'm going to be upset, I'm going to be miserable, I'm going to be upset with every surgeon in this room because of that. And I think really one of the biggest things is lack of awareness on how to prescribe. So what do you know? What after a hernia repair, how much do you give? Do you give 20 pills, 30 pills? For how long? We don't know those answers yet. I mean, some studies have done that. I've tried to show that, but we just don't know. So what are the consequences? So I think we're seeing that if you go on CNN, Fox News, whatever website you go to, there's a lot of consequences of overprescribing opioids. Nearly 55% of illicit opioid users reported obtaining the medications from friends or family for free. So that's really out there. And then among almost 75% of heroin users reported introduction to heroin through prescription painkillers. So this is obviously now, you're going to see some other implications of that. But so what do we do with those underused pills? So how do we educate our patients on how to get rid of these medications so we don't have those problems of people getting the pills from a family member, or I think there's stories of adolescents and young adults going into their mothers or fathers or brothers, sisters' cabinets, drug cabinets, and getting the pills from them. I think it's called farming is what they call it. But essentially, they're getting these pills and they're getting hooked. So we need to be able to educate people on how to dispose of them properly. So the FDA actually recommends combining them with water, dirt, kitty litter, dispose them in the trash. Or you take them to disposal events, take them to the police station, or flush them down the toilet. I mean, I think there's issues with that, flushing down the toilet, just because I think, obviously, with water sanitation issues. But I have to say, being in pain even, I'm not really aware of a lot of the FDA recommendations until, I just talk a lot on this, so I'm very aware of it now. But I mean, a lot of the people I talk to aren't aware of the FDA recommendation on how to properly dispose of these medications. So that's certainly something that the FDA needs to work harder on, and that we need to make everyone aware of a lot more, including our patients first and foremost. And it's interesting, very few people who were prescribed opioids postoperatively actually dispose of them properly. 9%, only 9%. And a lot of it, again, has to do with because we're not aware of it, or we're not making our patients aware of how to dispose of them properly. So, the chronic opioid issues, I'll just divert a little bit into this, is that it really, and why is it important, again, to the surgeons in acute pain? Chronic pain often begins with acute pain. So there are many other ways that people get chronic, to take chronic opioids. It doesn't always begin with acute pain, but just to give you an idea, that often begins with acute pain. And, just to really look at what are these benefits and risks for chronic opioid therapy. They're, just so you know, from if they do convert from acute to chronic, there really is no evidence for chronic opioid therapy. So we've looked at studies at a year, and there is no evidence for the support of chronic opioid therapy, ongoing chronic opioid therapy for chronic non-malignant pain. However, what we do know, and this is where it becomes important again even for acute pain, is that that the risks are dose dependent. So the more you give, the more of it you give, the higher the risks. So what are the risks? So most importantly, it's unintentional overdose death. So that's not only to your patients, but to family members. Addiction and diversion. So there's a certain percentage of these patients who get opioids who get addicted to these medications. And we've spoken a little bit about diversion. Then there's the other issues the common side effects that we're going to see with all opioids. So you have endocrine, GI, physiologic disruption. So constipation, obviously, is going to be important for you guys. Endocrine dysfunction, that's more of a long-term thing, but decrease in testosterone over time. Tolerance. So this is something that does take time to develop, but it can occur. Constipation again. Immunosuppression in some of these patients. So people who have been on opioids for a long time, and then you're taking them into surgery, there's a lot of issues with them, but perhaps one of them is immunosuppression prior to the surgery. And then opioid-induced hyperalgesia. I think we've seen this again, especially I've seen it in patients that are on high doses of opioids, and when I take them in for anesthetic, it is a lot harder to take care of them. So again, the problem with opioids, this is a New York Times article that came out June 5th, 2017, talks about the rising toll of opioids. So I'm just going to kind of focus in on it. So as you can see, about 59,000 to 65,000 people died from drug overdose in 2016. This was the most recent statistic. So it's more than the peak car crash in 1972, more than the peak HIV deaths, more than the peak gun deaths. This is all drug overdoses. This is not just opioids, includes everything, but most of them are due to opioids. About 20,000 are due to prescription opioids, and about 12,000 are due to heroin. What we're going to see, I think, over the next couple of years is that might flip a little bit. We're getting a lot of these people that we're having a lot of good measures that reduce the amount of opioids that we're prescribing. However, there is this flip of people getting medications from other sources or illegally, obviously. So they're getting a lot of not only heroin, but this illicit non-methadone synthetic medications like fentanyl. So what we're seeing with this Norco that they're getting on the streets is it's laced with fentanyl or carfentanil, which is a lot stronger than fentanyl, and it's leading to immediate overdose. And the problem, again, with that is that when they get this medication, they think they're getting Norco, which it's not. And on top of that, anytime you give naloxone to the patients who are on high dose, or they get a big dose of fentanyl or this carfentanil, it's pretty much not going to work because you need a lot more naloxone than that can take. So it's going to lead to immediate death in these patients. So again, just to kind of drive home a couple points with these statistics, the more we've written with prescription opioids, which we've done a lot of over the years, we see a parallel increase in opioid overdose death. So now it's gotten to this point where it is kind of really a national emergency. Trump declared it a national emergency. So this is actually good in one sense because it does allow us to really dedicate resources from a national and state level to things that need attention, like really education and medication-assisted treatments, et cetera. So with all of this opioid information, it's clear we have a lot to learn from it. However, we must also understand misconceptions with regards to opioid prescribing. So this is a busy slide, and I apologize, but I want to point out a couple things. This is Nora Volkow from, I believe, from the FDA, who talks about what are some major misconceptions. So I think I want to really point out that only long-term use of certain opioids produce addiction. That's not true. It can happen just like that. So after getting a prescription opioid after surgery, it can happen. It doesn't necessarily mean long-term use can cause it. Only patients with certain characteristics are vulnerable to addiction. Again, that's not true. Anybody can get addicted. We have tools that help to try to identify patients at higher risk for opioid addiction, but simply anybody can get addicted. And that medication assist for those who are addicted to opioids or misusing heroin or opioids, medication-assisted treatments like buprenorphine or methadone are actually very effective for these patients. It's not simply replacing one opioid with another. It's actually effective for these patients and certainly a lot safer. What are some of the things that we can see? I want to kind of point you to some of the major things, the overdose. So if you're taking more than 100 morphine milligram equivalents, that's going to be associated with not only overdose but addiction. A combination of opioids with benzos. I don't think that's a practice here, but if you see a patient on benzos and you give them opioids, they're much more likely to overdose. And then if you look at if you right after they start long-acting opioids, that might be another cause of increasing the risk of overdose. So things that I think are important for the surgical population here is that if you have an age older than 65, that's increased risk of overdose. If they have sleep apnea, renal or hepatic impairment, again, more likely to cause an overdose. So just keep that in mind when you're prescribing to these patients. And certainly if you can identify any of these patients with history of overdose, substance use disorder, all those things, those are important to look at with the factors associated with the risk. So recently there's a lot of guidelines that have come out. The CDC, National Academy of Sciences, California State has their own guidelines as well. What are the major things that you should be concerned about? So please, please, please do not start long-acting opioids for patients after, especially if they're opioid naive, and certainly after just any surgery. You know, my father had a knee surgery, a knee replacement, and he has never seen opioids in his life. He's 65 and diabetic, and they gave him 10 milligrams of OxyContin twice daily. And he was miserable. And we stopped it right away, and that's in Ohio, so just to give you an idea. So, that concerns me. I see that. That's a practice that was 2 years ago. So this is a problem that's happening. So please, please, please do not start long-acting opioids when initiating therapy. Try to prescribe the lowest effective dose, and I'll try and get into that a little bit in the next slide. And then long-term opioid use often begins with the treatment of acute pain. So now this is a CDC guideline that you should not prescribe more than 7 days worth of pills. And 3 days is usually enough. Okay? And again, I haven't seen this, but try not to prescribe ever with benzodiazepine or any sedative, because it really just is setting a patient up for disaster. So, how do we know what the lowest effective dose is? So this was an interesting study that looked at common surgeries, right? Thyroid and parathyroid surgery, 2 institutions, Rochester, Alabama, and looked at really what the most common opioid, how many pills were people taking. What's surprising is most people were taking, and they did some perioperative measures. They gave a good local anesthetic block before and after the surgery. So there are other measures. But really what's the most interesting thing here is that most people took less than 20 oral morphine equivalents. That's most people. So that's really, and 84% I think took 10 or less. So it's really remarkable. So they figured out at this institution what they can typically prescribe with confidence. So again, what I'd say here is that, and I can talk more about this slide if we have time, but there are studies that are out there that are really trying to determine how much we should be prescribing for surgeries typically, and within a certain amount of confidence. So, again, how do we get around this issue? What do we do for these patients? So one thing that we should do is prescribe the minimum quantity necessary. And that was on the previous slide, not the next slide, the previous slide. And this is what I want. This is what takes the time. but I think it's really important, is that counseling patients preoperatively to expect adequate pain control to function, but not for zero pain. We're so focused on pain scores that I think it's hard to get around, that we get away from focusing on function. And I think that's really important, so that we need to tell them that they might not be in zero pain, and that's not something that we should look for. Exploring and optimizing non-opioid options. So if there is a way that we can get away from opioids, if NSAIDs are okay or Tylenol, if we can do that for acute pain, that'd be great, if it's indicated. And this is something that we need to do probably more at an institution level. I'll probably get Dr. MacDonald to speak about this, but checking PDMP for each patient, your cures report, the prescription drug monitoring program. It's amazing how many people you'll see that have really some abnormal, aberrant prescription practices. So the patients that are doctor shopping. So that's something that we should be checking. Providing clear disposal directions. So that would probably help that a large amount of pills that are out there that we're not disposing of properly. So I just want to leave you with this. This is kind of more of a future directions, but this is something, with all this stuff that's going on, with all the problems that we're having, I want to say I think that this is an opportunity for finding solutions that will be viable long term. And I think we can all be a part of the solution. So the first thing, again, remember, is trying to figure out the lowest effective dose for our patients. And that will have to happen through prospective studies, I believe. So the studies that I showed were more retrospective. So we need to find some more prospective studies to really document how much we're using for these patients. But the other thing is, at University of Toronto, they're looking at different populations or different risk factors for patients. So we all know there are good studies, I should say, that show which patients are more likely to get chronic post-surgical pain. So if we can try to identify these patients or see high-risk patients before they ever get to surgery, I do think it would be very helpful in trying to manage them post-operatively and really trying to figure out how to reduce opioids over time. So again, if they're before, you can see, I'm not going to go through all this, but the before surgeries with increased risk for chronic post-surgical pain and after surgery. We can look at these risk factors, tick off some boxes, and then refer appropriately to people. Now, we at UC Davis, we're in the process of trying to figure out, with the anesthesia department, trying to figure out a way to do a transitional pain service or a perioperative pain service. But I think obviously it would be very helpful to get the surgeons involved with this process to get everyone on board at an institutional level. And it does take, it's not only the acute pain team and chronic pain team, but it's primary care surgeons, it's going to be psychologists that are going to be involved. And the reason why we need a lot of psychologists is you can see a lot of the factors associated with chronic post-surgical pain are really psychological in nature. So I think this is something that we need to look at very carefully and closely. So those are my conclusions. So surgeons can have a significant role with opioids and can have a major impact on minimizing issues with opioids and possibly play a role in keeping patients from taking opioids chronically. Institutional efforts, that's Dr. MacDonald. And then future goals I just got into. So again, I like to think of this as an opportunity. This is an opportunity to change what's going on, this epidemic, and be involved in it. So thank you for your time. I'm going to give it to Dr.
All right, good morning. Okay, hope you can all hear me pretty well with this mic. Okay, good, I'm set. All right, so I'm going to be talking about what's been going on at UC Davis in this area. A lot of it's been focused on ambulatory chronic opioid management, but that will touch on some of you. We have our policies. So if patients are on opiates for 3 months or longer, they're now officially chronic opioid users, and I imagine some of the patients in some of the surgery clinics fall into that category. Furthermore, some of the information that a lot of people managing these patients have, there's going to be a lot of tools in the EMR to help that. And so it's going to be a rich source of information for your patients when you're doing your preoperative evaluations to get a sense of where they've been with their opioid and pain management use. All right. So this should have been on his slide. Okay. All right. So here's a high-level approach. Like we do around here a lot, we form a committee. We talk about it and come up with some plans. So we did that. Developed a policy that is officially in place now. You may be aware, may or may not be aware of it. And we've identified a lot of experts around this area. We have resources. And created a bunch of tools in Epic, and we're continuing to create more tools. Now we're moving into the inpatient arena, and I'm going to talk about that as well, show you some of the things that it's very focused on surgery, opiate patients, and some training issues for patients and providers. We'll talk about that. All right, so the committee membership that we have, mostly a little bit focused on ambulatory, but it's me, Samir, pharmacies, a lot of folks here. And designers even too, and you'll see why we have professional designers involved in this process in a minute. All right, so the first thing we did was came up with a policy, and so I just want to share some of the highlights of this policy with the group. I think a lot of people around the health system aren't really aware of it. So the definition, like I mentioned before, is 3 months, and it's a little squishy. It's basically if a patient's using an opiate on most days of the week for 3 months or longer, that's what gets them in there. And a couple things that need to be documented for all these patients. One is that we want to have an initial risk assessment. Now, Samir talked a bit about that and identifying some of those risk factors for addiction, behavioral health issues, family history, personal history of abuse, and we're developing tools, so you don't need to remember all those facts. A PPA, patient-provider agreement, which is sort of the new politically correct term for the drug contract or narcotic contract that you might have heard of over the years. And education, both patients and prescribers. We'll talk about that a little bit more. And therapy plans should address non-opioid therapies like we talked about, tritylenol, NSAIDs, acupuncture, massage, exercise, other things. Don't go right to opiates first thing. If you have the luxury of starting somebody in opioids, kind of make sure you're discussing up front, well, what's the end point? And what are the goals we want to reach with this opioid therapy? And if we're not reaching those goals, we're going to stop the opioid therapy. Instead of just saying, let's do this, and then not have an end point at all. Patients keep taking it. It's not working so well. Let's give more, which has been the habit in the past. Instead, let's say, it's not working. Stop it. Try something else. Okay. And then be aware of the morphine equivalent daily dose that Samir also mentioned. So there's some debate about this, but around 80 milligrams a day seems to be where the risk of overdose really starts to increase dramatically. And at that point, you should be thinking about referring to pain management clinic or some other specialist with expertise in the area where the patient may be having the origin of their pain. Okay. And then regular assessment. So that was all the initial assessment, an initial plan. So on an ongoing basis, you should be looking for functional impairment and improvement. Again, looking at that pain score isn't that useful. It's very subjective. There can be patients who are highly functional and effective in their relationships and their job, yet they still may complain about 9 or 10 pain and want more opiates. Well, what are you really accomplishing with that? So treating to a goal of functional status is oftentimes much more effective. Even if their pain is high, if they're holding down a job, their relationships are fine, they're happy with life, they're not depressed, that's fine. You don't need to get that number down. Screening for aberrant use by urine drug tests, are they asking for early refills, that sort of thing. Assessing for those adverse effects we talked about, GI, endocrine, et cetera. And cures report reviews. Okay. So we decided those are the things we needed to do. What can we do in EMR to support all this? So you may know that there's a link to cures right in the header in Epic. If you can't see it, there's that little chevron over to the right, the 2 little greater than signs. It might be under there, but you can move that so you always have a button that links you right to cures. You still have to enter your password to get in there, but we're working on a process where if you're already logged into Epic, it'll take you right into cures. So hopefully we're going to get that in the next year or so. Then we have also created a letter template, which we'll show you in a minute. So if you do anticipate a patient being on an opiate for several months after a surgery, we've got a standard university-defined template that's very nice. We'll go over that. There's a chronic opioid registry. So the EMR now is actually trolling charts behind the scenes and tagging charts with patients who fall into this category. And we can use that to do things like report on them and show functionality to users to help them manage opiates. I'll show you some screenshots of that as well. Smart tools for data capture. We'll show over that. A calculator, Epic's building some of those for us, so that's sort of in limbo right now. And later on, we'll have even more sophisticated visualization tools called Synopsis. Health maintenance tools help people managing these patients. When are they due for their next urine drug screen, or when are they due for their next patient education or cures report review. So there's reminders built in the system to help with that. Okay. So this is the patient-provider agreement. And this is where the designers came in. So over at UC Davis main campus, there's Center for the Design and the Public Interest. So it's their graphic design department over there. And we engaged them in this project to help us design a lot of the patient-facing materials that we're developing. So you can see it's very nicely designed and formatted. And it really helps you walk through when you're talking to the patient about opioid long-term use, about all the things that the committee and the policy feels are important to discuss and bring up with the patient. It's 4 pages. You can have the patient initial each one. You have a section up here for goals of therapy, again, getting back to the idea of functional status. It's not, we're going to get your pain to 0. It's about, what do you want to do in your life, and how can we help you get to doing that? Whether it's, do you want to be able to take your kid to school every morning? Is it that you want to go back to work full time? That sort of thing. Okay. Urine drug screening. There's a new panel in the system now. You may have seen it. It's just, if you search for opioid, or UPT is probably the best synonym to get there. And it's a panel now. So you can order it, and it's got 3 orders. 2 are there by default. One's screening for drugs of abuse. The next one is actually measuring, looking for common opioids. So that's the sort of the negative and the positive screen. So you're looking to make sure they're not on cocaine or methamphetamine or benzos. And then the second part's to make sure they are taking an opiate that you've been prescribing, to making sure they're not diverting it. And then if they're on one of the rare drugs or less commonly used drugs, fentanyl, a few others, there's an optional order at the bottom for a GC mass spec order if you really want to get quantitative detail on exactly what's in their blood. So not commonly used, but it's there if you need it. Okay. So this is an earlier version of the tool that's we're piloting right now in primary care. It looks kind of complicated and ugly, but this is the initial assessment is kind of down here and collapsed right now, but it's the opioid risk tool, which is one of the tools Dr. Sheth alluded to, where you can prospectively assess their risk of having difficulty with opiates and becoming addicted. Stop Bang is also in there because patients, if you don't identify sleep apnea, they're really increasing your risk of respiratory depression and overdose from that. But what we found out in this pilot in the PCN is that this is too much. The docs don't want to do it. Surprise, surprise. So we're rebuilding it in a way where we're having office staff do a lot of this. A lot of these forms are going to be captured by the patient and entered by office staff. So it's being redesigned. And but in a few months, you'll be able to see over in the activity list in EMR when you're seeing patients, if they're on the registry, there'll be a new activity called Opiates. And you'll see basically this. And so if you're seeing a patient preoperatively, you can look at that activity and you can get a sense of how much morphine they're on, what their functional goals are, and all this information will be available to you. So look for that in a few months. Okay.
And don't mess with it, I'm presuming is what you, so I'm thinking, what is the role for the surgeon in this? You don't want us to be managing, changing. So I'm just thinking about, realistically, you've got somebody who's in this program. And now they're about to have an elective operation. So one thing you could say is don't do an elective operation.
No.
You could, how do you think, do you want us to manage our acute pain episode separately and independent and on top of this?
No, it can't be separate. It's got to be integrated. But it's the kind of thing where, no, you can use these tools, and this can be a flag to you for patients who might be problematic. But consultation with the prescriber, whether it's coming out of a pain clinic, but it's usually primary care. But contact us, and then we'll come up with a plan together.
Okay. I think that's the message, that if you see somebody who's on a program like this, before you do an elective operation on them, obviously we can't deal with this for the 50% of our patients who are not elective, but the contact the primary care, try to figure out who set this up. So is that an easy thing to figure out?
Yeah, it'll be up there.
And try to make a plan for their post-operative pain management together.
It's in the more current version, I believe, but there's sort of a primary prescriber field that'll be in there.
Because you don't want us doing this.
Not necessarily, unless you're prescribing it, and you're going to be prescribing it postoperatively for a few months, then you should.
Nobody prescribes, well, I don't know.
Hope not.
Do we prescribe medicine for a few months postoperatively? I don't think so. We're talking 4 or 5 days.
It's a minority,
Never mind.
but it's there. But yeah, I think most PCPs would be much happier receiving an in-basket message from you asking their advice for pain management than having you just go ahead and prescribe a bunch more opiates, is the bottom line. So provider education, so there's a PowerPoint, CME. So if this is a part of our policy also, so if you have a DEA license, you should have already done this. There was an email that came out from Dr. Kirk a few months ago. It's on the UC learning management system. So this is something, if you have a DEA, you should be doing. It's half an hour CMEs given for it. And then we've got a patient education video. We've got a longer version that we use for ambulatory patients and a shorter version that we're starting to use on inpatients. So if you've got a patient on the inpatient side who's getting opiates, they're going to be starting to watch this video and learn about the opioids. So you don't have to spend all the time going over everything that Dr. Sheth just went over. I'll show a preview of it.
Opioids are medications used to relieve severe pain. Opioids reduce the intensity of pain signals from your body and change how your brain perceives pain.
They're usually prescribed to people who are injured, are recovering from surgery, or are suffering from chronic pain. Norco, OxyContin, and fentanyl are common opioids, but no matter which medication you've been prescribed, there are some important things you need to know in order to take opioids safely. This video, along with the Opioid Patient Prescriber Agreement, will help you understand the purpose, risks, and safe use of opioid medication.
So it goes on for a few minutes, but you get the idea. Again, this is done by the Center for Design in the Public Interest, so nicely professionally done, appropriately gauged for patients that may not have real high health literacy. So that's going to be available also. The new thing that's also starting up, hopefully in the next few months, is called the Radio Project. And this is all focused on inpatients, and most of them are on surgical floors, so you're probably going to hear about this. So this is a mentored project from the Society of Hospital Medicine, and the idea is reducing respiratory depression from opioids, which is one of the 3 top adverse drug reactions that we see in the health system. And so the idea here is to assess patients' risk factors for respiratory depression and make that visible to all the people taking care of that patient. And we're going to have a few pharmacists that are also going to be monitoring these patients that are higher risk and offering some advice to help you manage their opiates. Okay. So 2 things are real-time, well actually 3 things I'll say, should have put that on. So a real-time risk prediction tool. So we've got a model that's based on, it's very simple, it's based on our experience in-house and our data and showing what the risk factors are for depression. And you see some of them here. Also stop bang, again, that was the screening for sleep apnea I showed in that previous screen. We're actually working to get that stop bang assessed on a regular basis for all preoperative patients. Probably going to start in the surgical admission center, and we're going to hopefully get a lot of patients screened there. A lot of them that get missed in pre-op, and those get still missed. Hopefully the floor nurses are going to capture this. So we're going to make sure there's reminders so we have this data on all of our perioperative patients. Then this is a column in a patient list. So you can add it to your own patient list if you want, but mostly it's going to be driving an automatically generated dynamic patient list that the pharmacists are going to be using for surveillance. And this is what it looks like. So it's just got a new column with their radio score, and it's basically just a sum of all these different risk factors. You see here, if they've got sleep apnea diagnosis, at risk for sleep apnea, if they're on a benzo, if they're on a PCA, age, creatinine clearance, et cetera. So these are all things we found really correlate strongly with adverse events. And then if it's 3 or higher, then there's going to be a new banner. And that's that sort of cyanotic looking color banner on purpose. So you may have seen that with anticoagulated patients, cancer patients, pregnant patients have similar kind of banners. So this is going to be for patients at higher risk for respiratory depression for opiates. Okay, so you'll start seeing this too in hopefully a month or 2. And then this is also going to drive some new nursing workflows. So not only are they going to do their routine vital signs that they do now after administrations, but they're going to be doing more detailed evaluations both before and after opiate administrations, including some end-tidal CO2 measurements. We're going to start experimenting with that on some patients as well. And then we're going to look at kind of an internal controlled trial with this. D12 and D14 are going to be the intervention units. So I think a lot of you work there and have patients there, so you'll be seeing that there. So the nurses will be checking these patients a lot more. And then I forget there's a couple control units that are, was it? DS11? Okay, thanks. And then they're going to have some of the tools available, but nobody's going to be bird dogging those patients. And we're going to see if it makes a difference. And then sort of the rest of the hospital is a different arm of the trial where they're not going to see any of these tools. And we'll look and see if the rates of these adverse events drop in these two intervention units. Okay. So that's where we've been, where we're headed with informatics tools around opiates. So I think we have a few minutes now for any questions that you may have.
Programs seems designed for the insured, elected patient, but we do burns where 30% of them have positive, a lot of them are in narcotics, and have no insurance or very little funding. For instance, participation into the payments 0.1%, because most of them don't have insurance.
Yeah.
And we end up being their primary care doctors too, because we can't get them to a primary care doctor. So that's a big problem for us. So how can we get facilitation to get them primary care doctors? It's very difficult for us to get help because our patients come back frequently. They're on narcotics before and they're on narcotics afterwards. It's a good percentage, but not all of them. So that's one thing that's going to be hard for our program, like Trip Thomas and our clientele are not the well-to-do people.
Right, not insured. How long would you say?
Years?
You have several years, and what percentage of your practice?
20.
20? Okay. All right. Yeah, that's a big problem that I can't solve right here today. Let me talk to primary care people.
We have a lot of difficulty just getting a primary care doctor.
Yeah.
And because they have, some of them are street people, but some of them are people who just don't have resources.
Yeah. Okay. Yeah, well, point well taken. I don't have a solution for you, unfortunately. Okay.
I just want to mention, I'm not sure when we're finally going to be able to have it up and running because we're still now having to deal with getting it through the EMR. But I've worked with a couple of people from pharmacy to put together a multimodal order set that, which really emphasizes the use of Tylenol scheduled up front. Because right now our current order sets have only PRN Tylenol, which is kind of a hassle for the residents when they're writing the orders. And so I'm hoping to have that online. Plus, we're also going to be looking at, and it's mainly for ACS and trauma, however, it will be out there for anybody who would be wanting to use something like that.
Yeah, there's a committee working on that. It's pretty early. We've only met once.
No,
or different one. There's another inpatient opiate
that
committee.
has already signed off on this order set.
Oh, that one. Okay, that other order set.
Yeah.
Okay.
The
Sedation.
The
Yeah.
committee that you're talking about, it's already signed off on that. We've already sent it back to the forms committee, so
That's
we'll
where it is.
have it soon.
Okay, and there's some other work around the opiate inpatient
And that's
matters,
the
and that's earlier.
And then the other thing that we're trying to put together, because it has to go against some of the JCO regulations, and you mentioned that Davis 11 is going to be the control. We're also going to use Davis 11 as a way of being able to try and approach patients differently, rather than using the pain score, but to come up with, it's considered to be motivational interviewing, where instead of asking them, what's your pain score, what number, is how are you feeling today, what can I get to make you more comfortable, looking at it in more of a positive sense to see if that makes any difference in how much opioids they would require.
Good point. Thank you. Okay. All right.
So occasionally we see patients that are getting prescriptions from us and that are also clearly getting stuff elsewhere.
Mhm.
They either smell like drugs or they upfront just tell you that they are getting stuff elsewhere. And I'm always afraid that as I'm writing this prescription, the next call I'm going to get is from the coroner. What am I supposed to do with these patients that clearly are, shamelessly sometimes telling you that they're going to be getting more stuff elsewhere if you don't give them more stuff right there and then?
No.
No, yeah, you can't. Well, where are they getting? Are they getting from their primary care? Where are they getting them from?
Some of them go to the emergency rooms. Some of
Yeah,
them
no, that's
like on
so.
the street.
Yeah, those are the doctor shoppers. I
Yeah.
just say no.
You
I mean,
can't.
if I look at the Cures report and I see they've been dispensed medications from lots of people, I just say it's not safe. I'm not going to risk your life to do that.
And you'll be supported. I mean, that's absolutely support. I actually think you'll get more trouble for prescribing to those guys.
Yeah.
So you have to be careful there. I would
Yeah.
absolutely check if they tell you, then absolutely that's one thing. But then also going a step further, if you can check that Cures, the PDMP. Some people will even. I know it's time. The biggest thing here is time, but calling those other prescribers.
How many
and-
people have looked something up on the Careers website to take care of a patient?
It's based on address, so sometimes it's hard to figure it out.
Yeah.
They can use different addresses.
Yeah. I pick all the addresses and
Yeah.
I just assume it's
Yeah.
all the same person.
And also, sometimes people use maiden name versus not. There's a lot of different, but for the most part, it is still a very good tool to use for our patients. Sir.
And Dr. Pevick had a
Oh, sorry,
question.
Dr.
He was,
Pevick, I'm
he was
sorry.
in line, I think.
Okay, sorry.
I'm struck by this seems in large part started by the external mandate that we were not implying patients' pain. It became the fifth vital sign.
Mhm.
This Likert scale or the 0 to 10 scale, which I never heard of before, all of a sudden was this externally mandated. Every time a patient comes in the clinic, every time I'm in a patient, every nurse comes in and asks what's your pain score. We weren't given a pain medicine, and this is where we are now. So
I don't disagree. I mean,
Totally agree.
it started even before that. If you go 10 years, 1980, there was an article in New England Journal that said nobody's going to get addicted from pain meds if you use it for pain. So it all started. It's been going on for a long time. This process is not just. We're now dealing with the ramifications of what started. Maybe what you said. The pain of the fifth vital sign. JACO came out. Institute of Medicine in 2011 said 1/3 of our patients are in pain. What are we doing about it?
Yeah.
So. I don't disagree. I mean, this is where, again, I know that there's a problem, but we have to look for solutions now.
Pain's
that's
a problem,
the issue.
but opioids are not the answer.
Right.
So just a couple of things. First, narcotics, opioids have been used for like hundreds of years, right? We can't do any better than that. That's kind of ridiculous in medical science. There are other things we can use, other modalities that reduce narcotic use. We're not trained to do this. We have to stumble upon it ourselves and figure it out. I was hoping you guys would have touched on that during this talk because it's great that we know that there are resources. I can tell you there are no resources for pediatrics. Zero. There's no pediatric pain service right now. And it's frustrating as hell to the pediatric providers who have to deal with these issues as well. So please, with your departments, start addressing that issue. The second thing is, we have a lot of ICU patients, like the burn patients, who are on chronic narcotics in the hospital, and we have a hell of a time convincing our ICU docs and nurses to turn the damn narcotics down and use other ways to settle those patients. That's where training needs to happen in our hospital. These are great EMR things, but I'll be honest with you, that's pissing in the wind. It really is. Compared to what a lot of the providers are seeing who take care of the most critically ill patients.
Okay.
So I
That's a
don't
good
disagree
point.
at all. I mean, I wanted to go in a little bit more detail, but in the interest of time, I think there are some efforts that are going on with regards to trying different ways to manage patients' pain without opioids. I also don't disagree with the pediatric pain issue. Where I trained, we had a huge pediatric pain service, and it was part of it was a really big part of my training. I know I spoke with Dr. Farmer about this. It's more of it's an institutional kind of effort to do this, and we'll be supportive of it. I'll tell you that. It's just a matter of getting the money and the time to do it, and that's what we're facing. I don't disagree, though. I'm not trying to say shirk it onto somebody else. I don't disagree, and I do think that this opportunity for at least some sort of perioperative home would be a good opportunity for us to identify patients, to figure out, to educate, to really figure out how we can help manage our perioperative patients who are undergoing surgery. So, but thank you for that. I think I agree. I don't disagree. Sir.
Yeah, I mean, I have the alternative viewpoint as usual, not to throw the baby out with the bathwater.
And as Dr. Pevick said, these are a lot of oversimplistic reactionary approaches, and then you sort of slip in there, well, non-malignant pain, and you have to be careful about the message that there are, opioids are not, they've been around for 100 years for a reason, and so we can't start under-treating pain because now everyone's paranoid about, appropriately so, opioid overdose and so forth. So, it has to be much more of a nuanced approach of, what is appropriate ways to manage pain, what are the tools in the toolbox, and how do you effectively manage pain without sort of just dismissing everyone's complaints.
And to your point,
that's not necessarily a message for you guys, but a message for the audience as a whole.
And to your point, I think the risks and it's really a careful risk-benefit analysis for each patient. So that's certainly a message that I try to. I gave a couple presentations this past weekend, and that's certainly the message that I try to relay. But I don't absolutely. I think that's certainly important when you look at it. Sir.
What are the barriers for the hospital to provide a safe drop point for unused?
Give Scott that.
I haven't been part of any discussions around that. I think there's liability concerns about policing all that and tracking all that, and documenting all that. There's a lot of bureaucratic overhead for that.
Could be a great resident project.
You can't take it to the pharmacy,
There is a paper on a resident run at a hospital narcotic drop-off. It wasn't just for narcotics, it was for all prescription drop-off. It was a resident run at a hospital. And they cataloged the type of drugs they got back. And narcotics were the number 1, antihypertensives were the number 2, antidepressants were the number 3, medications were dropped back off to be disposed of. And they actually did a count of how many there were. I can't remember the reference. It may have been in one of these annals articles or not. Pretty fascinating, actually. And then the residents sold them, and then they had a big
So we know we all have a patient population where there's a good percentage that come back to the ER with uncontrolled pain, and there we have to admit them in a consult pain pharmacy and acute pain anesthesia and psych and try to find a plan to send them out. But when we can't get MS content prescribed by their primary care doc, and they're asking us to do it so they can leave, who do we go to for help? Because as a chief resident, I don't really want my name on their MS content.
Well, why are they? I get, I always get concerned when patients ask for specific medications, and that
That's a red flag.
they're allergic to gabapentin or Lyrica and all this other stuff, but they can take MS content and nothing else. So that always is a red flag for me. Again, I think this is the hardest part. It takes that time to really make those phone calls to people, to make everyone aware, and then documenting why you're not going to prescribe it for that patient. Listen, I know this is not easy by any means, but that's what we have to do for these guys. And when they're coming in for that, I think the ER is doing a little bit better job of making sure that I know there's a lot of people on our committee that talk about it, but of trying to make sure that we're trying not to admit those patients that are just trying to come in for pills and whatnot. So.
And that is the medication that's recommended to prescribe by the pain pharmacist.
Oh, got it.
Should we be writing it, or do we send them to somebody else to write it?
And they have a PCP?
Often the PCP doesn't want to prescribe it after surgery. They say, you're the surgeon, you do it.
Well, if it's anticipated to be a short-term thing, I think that's legitimate. But then it becomes chronic and not a post-operative pain anymore, and it's now a chronic pain situation, that should go back to PCP. So that deserves a conversation, I think.
So maybe we could think about coming up with finite timelines for us when it's the surgeon's responsibility, when it's somebody else's, and seeing a lot of resident questions. In fact, let's finish with the residents.
Can I just if they weren't on MS Con before, they should certainly, even with that recommendation, I have to say they should not be on it after surgery. So I would really make sure that that's not the case, because that's something that will be supported by guidelines. You can call me and I'll talk to the pain pharmacy if that's the case, because that's something that's really out there that we should not be doing.
Yeah.
So, okay.
But there are PCPs out there that have gone, like he was saying over there, the pendulum has swung too far the other way, and they're not willing to prescribe opiates appropriately when the patient does need it. So it's just a matter of professionalism and discussion and communication.
I have a comment about our opioid use in the acute setting, and that is that we will often speak with the anesthesia pain team either preoperatively or postoperatively. Can you get tap blocks? Can you get an epidural? epidural, a PET block for a mastectomy or whatever, and it's either not done preoperatively because it will delay the case too much, or it's not done postoperatively for reasons such as the patient wasn't awake enough to consent and they didn't feel comfortable consenting a family member, et cetera, et cetera. So then it's midnight and the intern's getting paged for the 11th time by the nurse and the PCA gets started and we're off on this opiate road. That could have been avoided if we had a larger acute pain service or something that was a little bit more accessible or planned in our preoperative visit. Like, okay, we know you're having an elective surgery. It's going to be a colon resection. It's going to be painful. Let's all just say 2 weeks prior to the surgery, you're going to need CAT blocks. And I don't see a lot of that. I don't see that system becoming more robust or conversations about it. What I do see is my intern telling me every morning I had to start IV pain medication.
Yeah.
Is there any conversation going on at the
There is.
upper levels about this?
Well, there's conversation. I know that for sure. I just went to Grand Rounds 2 weeks ago for anesthesia, and there is conversations about this. This is certainly something that they're forming They're forming a committee. This is the acute pain side. I'm on the chronic, but they are working on, and that's why I put that slide up there, because that's kind of the model that they're trying to use to make sure that they identify high-risk patients, one, and then two, trying to figure out alternative modalities in order to treat them. Local anesthetic blocks before or after surgery are certainly a big part of it and can reduce the amount of opioids. Right.
They get a PEC block, they go home with 7 Norco, that's fine.
Yep.
Before the PEC block, it was the send them home with 60 or whatever. And we're breeding opiate addicts. There's a study that came out last year that said 10% of malignant patients undergoing curative surgery for malignancies are addicted a year after their surgery, which is just
it's outrageous.
Okay.
I just want to know how we can get involved. I think a lot of us care about this issue, and I wanted to know what actions you're taking to improve surgical providers and steps moving forward.
I mean, I'll get in touch with some anesthesia providers too to find out if they're involving the surgeons at this point. I hope they are. I mean, but I'm not 100% sure yet on that. So I'll find out. I can find out. And who should I let? Should I contact you, Dr. Farmer, Dr. Fisher?
Yeah.
Okay.
Okay. Maybe we have a question time for one more question.
I do a lot of mastectomy. I use preoperative pain blocks, I use pain tea. I do a variety of things, but it's well documented. 25% of mastectomy patients have long-term pain. The only way really to deal with it is dealing with their acute pain aggressively is the only thing that's shown any difference. So, starting at 2 weeks of their post-op, if they are having things that are uncontrolled, that are nerve pain, that are problematic, that I've dealt with, gabapentin, I've dealt with a variety of things, trying to get them off of opiate pain medicine. I send them to chronic pain. I try to get them into the chronic pain service because that is what has been shown to make a difference and make a difference in patients. And this is something that you guys really aren't addressing here, is the length of lapse of time. My patients will take 8 weeks to get in. When I know at 2 weeks that they're a problem, that they need help, they need pain blocks, they have things that we can do to take care of them in the first 6 weeks, and then it's 8 weeks before they get in. So a lot of the things that you're telling us about changing their actual medicine, I have data. I have lots of data that can tell that, and there's no way to change it. So you guys are only looking at the acute setting and sort of in the hospital is what all of this looks like it's focusing on. And it's really frustrating for those of us that have outpatient practices that there are ways to actually fix this and change this, and we don't know where to go.
I don't disagree with treating acute pain, but I really, again, remember I think what factors into those patients who get acute pain, right? So I think that there's multiple etiologies to that, and from my experience, pain blocks alone sometimes aren't it. So it's really, and I agree, at the chronic pain situation, yeah, I know. So I know that I've looked at the data recently with our triage to appointment. They say it's, from what my medical director says, about 7 to 14 days. So I think we're working on, it's not, okay. So, okay. So I'll go back, but I understand. But I don't disagree. I think the earlier we get to at least address the problem, may not be nerve blocks. It might be something else, but just to give you a heads up. But I understand.
So I just want to thank you guys again for coming, and obviously I'm going to apologize a little for sort of the attack. Please.
Very used to it.
But I do think, there's a wealth of knowledge here in terms of, all the residents who are at the front lines of some of these issues, who really get it, as opposed to a lot of people who, make all these policies but don't actually take care of patients or don't actually know how to work the electronic medical record, but come up with a plan. So I think this is your knowledge base in terms of trying to get some of this. I also think we've identified a few sort of specific, patient diseases that we could put a task force together to sort of work around a small group of people while we're trying to solve the bigger problem. Clearly, we don't have an adequate, perioperative anesthesia consult thing. I mean, every single patient of every single age having an elective procedure should be part of that. I know the anesthesia department wants to do that. I think we can help. I think we should leverage this situation to do kind of what we should have been doing a long time ago anyway, and make our anesthesia providers a bigger part of that whole process. Acupuncture, a lot of these alternative approaches, many hospitals have big units that are rounding every day on the patients and providing these kinds of services. So I think we need to turn this into an opportunity. And I think we should take all this passion that I kind of heard here and, put it together and come up with some solutions, because the solutions aren't that hard. So thank you for stimulating this conversation. And
welcome.
You guys were brave and left your
email us.
address. So let's